Welcome to the virtual Lunch and Learn for One CME. I'm Susan Bray, the East Valley Navigator for Dignity Health and your host today. Today we have Dr. Rachel Bond with us. Dr. Bond is a board-certified cardiologist. She's focused on women's heart health and has authored several articles referencing sex and gender differences and cardiovascular conditions that predominantly affect women. She's also written opinion pieces aimed at addressing health equity, reducing health disparities, and promotes the professional development of women and minorities in the health science profession. Today, Dr. Bond will be sharing some of that content with us and how it relates to your everyday practice. But first, we will go over a few housekeeping issues to make sure everyone's able to claim their CME following this discussion. If you joined us by computer, please click on your screen and then click on the chat bubble. That should appear at the bottom of your screen as you hover over it with your mouse. This will activate the chat box. Please put your email into the chat and we'll send you a link, email link with instructions to claim your CME. The email will include a survey which is required in the CME world to claim this credit. If you're interested in future virtual CME so that we can receive, we'll receive your email and send you out future invitations and WebEx links. If you're calling in, you can text me at 928-699-4797, or you can email me at susan.bray, B-R-A-Y, @dignityhealth.org to get the instructions sent your way. Please type in any questions you might have during the presentation, and Dr. Bond will address those at the end of the presentation. And with that wrapped up, we'll get to the good stuff. I present to you Dr. Bond.
Thank you so much, Susan. I first and foremost would like to just thank all of the healthcare workers that are listening in today, particularly those that are on the front lines of this current coronavirus pandemic that we're experiencing. I think this virtual Lunch and Learn is a testament to really the future of how we're going to be interacting, not just amongst each other, but also amongst our patients. So without any further ado, today we're going to be talking about really when do you want to consider the use of a specialist, particularly a specialist focusing in on women's heart health. And before I get started, as Susan mentioned, I am the medical director for the Women's Heart Health Program here at Dignity Health in Arizona. So a large part of the talk is going to be focusing in on the importance of having a women's heart health program and when you, as a clinician out in the community, may want to consider utilizing the services of our program. To begin, I have no disclosures at all. And again, our learning objectives at the conclusion of this activity, I hope that you will have a better understanding of utilizing guideline-directed medical therapy and procedures and really viewing it as it pertains to sex and gender. And also my hope is that you'll understand female-specific and female-predominant risk factors for cardiovascular disease. You'll also develop individualized strategies for female patients at greatest risk of cardiovascular disease, as well as evaluate the need for a women's heart health specialty program. So to begin, I always like to begin with this graph, which is from the Heart Disease and Stroke Statistics of 2019. And what we really see here is that before the 1980s, men were dying at a much higher rate from cardiovascular disease than women, men in blue, women in red. And it really wasn't until the mid-1980s, really 1984 to be exact, where we started to see disproportionately lower numbers of death in men compared to women, where women were having a steady increase. And a lot of that had to do with the advent of new technologies such as angioplasty or medication such as statins. However, all of those treatments were disproportionately being given to men and not women. And it really wasn't until 2000 when somebody started to make a point to really hone in on, well, why is that? The reason is that there weren't a lot of sex-specific research studies. And because of that, women were not really being enrolled in trials to see if these medications and management also help them in terms of lowering their risk of cardiovascular disease. And it was really the American Heart Association, as well as the American College of Cardiology, that pushed to have campaigns such as the Go Red for Women campaign, which helped to increase awareness to not just the community, but also clinicians. and also with the American Heart Association joining the American College of Cardiology to create sex-specific guidelines. And we began to see a steady decline in the number of deaths for women and men. Towards the later years, we're now seeing that this trend is going in the wrong direction. And despite that, we know that the vast majority of the community still thinks that breast cancer is the greatest risk for their female patients. And when I talk about the community, I don't just mean patients, I also mean doctors alike. The reality is that where 1 in 31 Americans will die from breast cancer, we know that women are 10 times more likely to die of heart disease than breast cancer alone, to the point that 1 in 3 women will die from cardiovascular disease. Or cardiovascular disease, including stroke, so such as heart disease and stroke. And the fact of the matter is that 1 woman dies every 80 seconds from a cardiac condition. And that we know is disproportionate. So the fact is that when we look at how well we've been doing, we like to divide it by age group. And heart disease deaths have declined steadily over the past 3 decades in people above the age of 65. However, we've seen a much slower improvement in those less than 55, particularly the age range of 35 to 54 to be exact. And it's particularly in women, and it's really more so particularly in women of color. And it really asks the question, why? Why is it that we're not doing as well a job in lowering the rates of cardiovascular disease in those that are at greatest risks, which tend to be young women, particularly young women of color? And one reason may be really looking into this abstract picture that I like to always present, because when we think about it, a large portion of you may see a young woman. Here I will outline her hair, outline her wearing a hat, outline her profile with her jawline, her neck, and her necklace, as well as fur coat. But another half of you may see an older lady, which here you'll see her hair as well. You'll see her profile with her nose, her mouth, and her long chin, and her fur coat as well. But the fact is if I didn't highlight it to you, you wouldn't be aware of it. So that's really what heart disease in women is like, that in order for us to understand that it's our greatest risk or our patient's greatest risk, there has to be awareness. And the fact is that awareness is lacking. Even still to this day. This was looked at in 2012 to be exact, where they looked at starting from 1997 to 2012, how well did the population understand that heart disease was their greatest risk? And although there was an improvement in trend from 1997 to 2012, it wasn't really in all ethnicities and races that were looked at. There was a significant improvement overall from 30% to about 56%, but it was predominantly in those that identified as white, and less likely in those that identified as Black or Hispanic, which again are the populations that are at greatest risk, particularly females, for dying from cardiovascular disease. And awareness is not just lacking in the community, it's also lacking in physicians. When we looked at this most recently in 2017 in the Journal of American College of Cardiology, we saw that only 39% of primary doctors make cardiovascular disease a top priority for their female patients. Similarly, only 22% of primary doctors or 42% of cardiologists actually feel well prepared to assess cardiovascular risks. We're going to be talking about these risks, not just the traditional risk factors, but the sex-specific risk factors we should be honing in on. And the reason that awareness may be lacking, or the reason why we may be seeing higher rates of death in our younger women, is because we are still viewing them through bikini medicine. Where, what does that mean? Really that bikini approach where we're focusing more on just the breast and reproductive systems and ignoring the rest of the women as part of women's health. And we know that we're doing a disservice to our patients when we do that. And one reason we may be only honing in on really the breast and the reproductive organs is because the fact of the matter is that research, particularly cardiac specific research, disproportionately doesn't allow or doesn't really think to include women in trials. And we know that women make up less than 30% of clinical trials for heart failure and coronary artery disease, where they have a higher abundance of enrollment tends to be hypertension or atrial fibrillation. And we actually see an overabundance of women being enrolled in trials specifically for pulmonary hypertension. But really where we need to increase the number of trials for, or at least inclusion of women in trials, is for heart failure and coronary artery disease, which are really their greatest risks of mortality. So we have to do a better job in ensuring that we're enrolling our female patients. Another reason why we may be seeing higher rates in our younger women is because the fact of the matter is that cardiologists in general are fewer women. So we have fewer than 1 in 5 cardiologists that are women. And if we were actually going to look at the actual statistics, a general cardiologist, which is what I am, I only make up about 13% of the population of cardiologists out there. If you were to look at more specialized cardiologists, such as interventional cardiologists or electrophysiologists, the numbers are even less. And I can say that data has shown that if you are a female doctor, you are more likely to be aware of the female-specific risk factors for heart disease, as well as the atypical symptoms, and thus you may help the patient slightly better. We also know that data has shown that men that are colleagues with female cardiologists tend to think about treatment and diagnosis of their female patients a little differently. So there is a benefit in increasing the number of women in cardiology. Now, this leads us to the big question. If we're seeing that there are higher rates of death in younger women, what is the cause of that? Well, is it because perhaps we're not following guidelines equally in women versus men? So I'd like to really focus in on that in the next topic, which is going to be looking at sex differences in treatment. And I think the first thing that's important for us to focus in on is the management of an acute coronary event, such as a myocardial infarction, specifically a STEMI, which is our greatest risk. And we see that this was looked at and Get With the Guidelines, which is published in Circulation. And what we see is when we compare women to men, really the only thing that women did better than men was die in the hospital from a STEMI, or overall an acute myocardial infarction. Really what this paints the picture of is that women were less likely to receive early medical therapy such as aspirin or a beta blocker or even a statin. They were less likely to be referred for an invasive procedure such as a cardiac catheterization. And if they did have a cardiac catheterization, they were less likely to undergo percutaneous coronary intervention. They were also less likely to meet door to balloon time or door to needle time, unfortunately. And what we see is that when we divide these ladies by age group, it's really the young or the very young, less than 35, and those between the ages of 36 to 45, where we see this greatest disproportion, where we see such a significantly higher mortality rate. And a lot of it also had to do with the fact that after their event, they were less likely to receive a lot of the medications that would help them recover, such as beta blockers or ACE inhibitors or lipid lowering therapy. They were also less likely to have a blood pressure that was at goal at discharge. Now, I'd like to hone in on door to balloon time because I think this is so important when we're dealing with an acute coronary event. We know that the sooner we diagnose somebody with an acute coronary event, particularly a STEMI, it can be completely life-saving because time is muscle in the cardiology world. And for women, we see that those that presented directly to the emergency room had an 8-minute longer time to treatment than men. And that time to treatment compared to men was even longer if they were a transfer, where it was about 30 minutes longer. And this is specifically looking at younger women. So younger women have an 8-minute longer time to treatment compared to males of their same exact age. So we have to do a better job in identifying these patients early and ensuring that we provide them that immediate care as we would their male counterpart. Now, when we think about once we get them through that angiogram or that coronary catheterization and we decide on what treatment management there should be, we have to ensure that they get discharged on all the proper medications. And when we look at women in particular, we know that they're less likely to be discharged on a baby aspirin, a statin, and meet blood pressure goal. I also want to emphasize cardiac rehab. So cardiac rehab is such an important part to anybody who presents with an acute coronary event because we know that it can reduce death by 26%. It could also reduce the need for rehospitalizations or repeat heart procedures. And men are a third more likely to be enrolled in cardiac rehab than women. Women are also referred less likely, but when they are referred, they're less likely to go and they're less likely to complete it. And one thing that I think has been great that has been looked at is, well, why are women less likely to complete it or go? A lot of it may have to not just do with referral barriers, but also adherence among women that may not feel comfortable having co-ed cardiac rehab, for example. So people have looked at women-only cardiac rehab. They've also looked at home-based cardiac rehab. And I think, more data is needed to see if this is a way to kind of ensure that women are more likely to complete it. But I think that it's also progressive in seeing that if this can kind of make changes, because we know how important cardiac rehab is to our female population just as much as our male population. Now, because of the fact women are less likely to receive the medications on discharge and also to be referred to cardiac rehab or even complete cardiac rehab, they are more likely to have rehospitalizations after an acute coronary event. And we can say that this is even greater if they're less than 55 years of age, particularly if they're a female versus male. So it's such an important factor that we really need to ensure that our young women are being diagnosed early, that we're providing them proper treatment, and we're providing them proper follow-up and follow-through in the future. Now, what about heart failure? Because we talked a lot about acute coronary events. So let's talk about heart failure. So we have two types of heart failure out there. We have heart failure with reduced ejection fraction, which is typically defined as an ejection fraction less than 40%. And then we have heart failure with preserved ejection fraction, which by all means is really diastolic heart failure. And we know that heart failure with reduced ejection fraction, women are less likely to receive evidence-based therapy, such as the medications that are guideline directed, like a beta blocker, Entresto. If not Entresto, then an ACE inhibitor or ARB or aldactone, for example. They're also less likely to be referred for an ICD, which if their ejection fraction is less than 35% is indicated for primary prevention if their heart muscle hasn't recovered, at least after 3 months of being on highest amounts of tolerated guideline-directed medical therapy. They're also less likely to receive cardiac resynchronization therapy, which implies that we then pace their RV and LV together, which data has shown that that can not only improve ejection fraction, but reduce the need for rehospitalizations. And they're less likely to receive that despite studies showing that women have better responses to it. They're also less likely to receive left ventricular assist devices if their ejection fraction is extremely severe and they're extremely symptomatic. And they're referred much later on in their clinical course. Similarly, heart transplant, less likely to receive because they're less likely to be referred for that. Now, when we think about heart failure with preserved ejection fraction, although it's more common in women, we right now don't have many guidelines on not just diagnosis, but also treatment. What is the best treatment modality for heart failure with preserved ejection fraction? Right now, for the most part, they're trying to control a lot of the things that could lead to it, such as blood pressure and volume overload, and of course, encouraging exercise, but more data, of course, is going to be necessary. Now, what about arrhythmias? Similar to acute coronary events and heart failure, women are less likely to receive adequate care when it comes to arrhythmia treatment. And I want to focus in on atrial fibrillation in particular, because atrial fibrillation is really the most common arrhythmia when we think about it. And we know that women are less likely to be referred to an electrophysiologist. They're also less likely to receive oral anticoagulation. If they do have atrial fibrillation, and they've failed, let's say, multiple cardioversions, for example, and they remain extremely symptomatic, they're less likely to be referred for catheter ablation, although we see that there are similar success and improvements in quality of care in women as compared to men. We also know that they're less likely to have a transesophageal echo or direct current DC cardioversion, and they're also less likely to be prescribed a rhythm control medication if they are, in fact, symptomatic. Similarly, we see this with peripheral arterial disease. Women are less likely to be screened for peripheral arterial disease. So when they do have it, although a vast majority may not have symptoms, meaning they're asymptomatic, and we know that asymptomatic PAD is twice as common in women as men. And because of that, they may have greater functional impairment and lower rates of revascularization, but once they do get diagnosed, they usually have increased likelihoods of needing emergent procedures, meaning that they present with more likely critical limb ischemia because they may have been asymptomatic for such a long period of time, and the thought of screening them was not equivalent to the thought of screening a man. So when they do present, they may have critical limb ischemia and they may need more of an emergent procedure. So screening our patients is so important, particularly understanding these disparities that we see in women and sort of the fact that asymptomatic PAD is twice as common, ensuring that we do a really good pulse exam is very important, and even deciding to do an ankle brachial index, for example, and depending on if that's abnormal, arterial Dopplers will be very key and important. Now, what about valvular disease? I talk about the two most common types of valvular disease in the United States, which is aortic valve stenosis and mitral regurgitation. And specific to aortic stenosis, we know that any patient with symptomatic aortic stenosis requires some form of treatment management. And that could be either a surgical aortic valve replacement or a transcatheter aortic valve replacement, depending on their risk. We also know that women, although have higher 30-day operative mortality for surgical aortic valve replacement, tend to be referred more likely for surgical AVR compared to transaortic valve replacement. And although women have more upfront risks of complications, and a lot of those include more access site complications, such as vascular or groin complications, they have actually better long-term survival compared to their male counterparts. And despite this, women are less likely to be referred, especially women of color. And it's for that reason why our Women's Heart Health program works really closely with the Structural Heart program at Dignity Health to ensure that we see proportionate referrals for both women and men. And we're educating the doctors in the community to really diagnose these women early and get them plugged into our structural valve programs. Now, not only really asking the question, how well are we doing with the guidelines, it really paints the picture of, we see based on all the studies that I've just shown or all the data that I just reviewed that we're not doing a good job in terms of providing equal care for women and men when it comes to guidelines. And in all areas, going all the way from acute coronary syndrome to congestive heart failure to arrhythmias to PAD and to valvular heart disease, we see that we do not follow the guidelines equally in women and men. And it's really the implementation of Women's Heart Health programs that are really allowing for policy changes at the hospital level to ensure that we are actually implementing a lot of the guideline medication to our women just as much as we are doing it to our men. And that's one importance of having a program. This then brings up the question, do women experience cardiovascular disease like men, or are there sex differences in diagnosis? And to answer this question, I'd like to really go over more of a history lesson. So we have Yentl, who was the heroine of a 19th century short story by Isaac Bashevis Singer. She had to disguise herself as a man to study the Talmud, and being just like a man has historically been a price women had to pay for equality. In 1991, Dr. Bernadine Healy actually noted a discrepancy in including women in trials, particularly cardiovascular trials. So for decades, women were treated as either second class, or when it came to medical care, they were assumed to be just like little men. And that's something called Yentl syndrome, where we treat women very identical to how we treat men, but we know that women present differently, particularly from cardiovascular disease. And one way we present differently is through symptoms. So let's talk about heart attack symptoms. So what does the textbook say when somebody's presenting with a heart attack? We typically see this picture of a male where we have sternal heaviness that could radiate to the jaw and or the left arm, usually brought on by exertion or stress and relieved by rest or nitroglycerin. But what else can happen in real life, particularly for women? So yes, we can have discomfort or pressure or squeezing that feels like you have a ton of weight on your chest, or as most people like to say, an elephant sitting on your chest. But then a third of the time you could have atypical symptoms, and this disproportionately occurs more commonly in women than men, where you could have upper body pain, shortness of breath, jaw pain, extreme fatigue, breaking out in a cold sweat, feeling nauseous or lightheaded, or having sudden dizziness, for example. So it could sometimes be confusing for us as clinicians when women present with these atypical symptoms, because if our suspicion for heart disease is low because we're not thinking about heart disease because of their age, or because of the fact they don't have the traditional risk factors, or because of the fact we haven't screened them for the more female-specific risk factors, we may delay their diagnosis, which could ultimately delay their ability to recover accordingly and receive appropriate care, which could increase their risk of mortality. And this is even more confusing when dealing with a pregnant woman, right? So we know that women during pregnancy experience symptoms, And it's really important for us to hone in on this because the fact of the matter is that ACOG, which is the American College of Obstetrics and Gynecology, has most recently, in the last 1 to 2 years, teamed up with the American Heart Association, the American College of Cardiology, to focus in on cardiovascular disease during pregnancy. Because when we look at it, the United States has the worst maternal mortality rate within the developed world, cardiovascular disease being the leading cause of all pregnancy-related deaths. To put it into perspective, about 4.2 deaths occur per every 1,000 live birth. So cardiovascular disease accounts for about 26.5% of pregnancy-related deaths. And we see that these disparities exist in cardiovascular outcomes, particularly disproportionately in those women that are non-white and are of lower income. Particularly Black women. Black women are dying at the greatest rates from maternal mortality in the United States. And they're 2 to 3 times more likely to die during their pregnancy and the immediate postpartum period compared to a white woman. Contributing factors include barriers to pre-pregnancy cardiovascular disease assessment, missed opportunities to identify cardiovascular disease risk factors during the prenatal care visit, gaps in high-risk intrapartum care, and also delays in recognition of symptoms during the puerperium. And that's why ACOG released sort of this guidance to really figure out how can we best address the leading cause of U.S. mortality deaths, which is heart disease and pregnancy. Before we talk about that, it's important for us to understand why it's so confusing. Because during the pregnancy, we have a lot of changes in our hemodynamics and our cardiovascular structure. So for one, our intravascular volume increases by nearly 50%. And with that, our cardiac output increases by nearly 50% as well. We also know that our patients have an increase in their heart rate overall and typically a decrease in their systemic vascular resistance. We also know that the stroke volume increases by about 30%, and we typically see that the blood pressure can drop, both systolic and diastolic occurring more in the mid-pregnancy. And we also know that the venous pressure in the lower extremities can increase, and that's why about 80% of pregnant women do have edema or swelling in their legs. But the fact is that we shouldn't ignore signs or symptoms that may be a precursor to us understanding that the female patient has a risk of having a more aggressive cardiac complication. Because when we think about it, yes, although a lot of pregnant women can complain of shortness of breath and sometimes even chest pain, which we tend to think is more reflux related, we know that there are certain situations, particularly when you go to that, hey, this is when we may need a prompt evaluation from a maternal heart team, for example, where you have an obstetrician working conjointly with a cardiologist who specializes in pregnancy and heart disease. Because let's say this patient is having shortness of breath. If that shortness of breath is not occurring with the daily activities of living, or it's not, or it's starting to interfere with, I should say, activities of daily living, and it's occurring at rest, that's a red flag to say, well, that's not normal pregnancy. We also should say, well, if they're having difficulty laying flat, for example, or they're feeling extremely short of breath, or we're noticing that their vitals are completely out of whack with their blood pressure being very elevated or their heart rate persistently being above 120, this could be a red flag that we need to get them in to see a cardiologist much sooner and ensure that the obstetrician and the primary doctor are collaborating all together with the cardiologist to ensure these patients are being identified sooner rather than later. And I love the fact that the ACOG joining with AHA and ACC really mandated sort of an algorithmic approach to this. And I think the most important thing to take home from this slide is that women that we really should be thinking about that may be at greatest risk during their pregnancy, we should really be screening for these signs and symptoms, are those above the age of 40, African Americans, women that had pre-pregnancy obesity, pre-existing diabetes or hypertension, of course, substance use, and any history of chemotherapy, which particularly could have been cardiotoxic to their heart. And it's very important that we talk about this because we have the ability to hopefully prevent any complications from occurring. And it's important that we follow these women, not just during their pregnancy, but also in the postpartum, because the vast majority of the time we see that these symptoms are occurring in the postpartum period, usually about 6 weeks after the delivery. This is just an example of a pregnancy-induced myocardial infarction where you can see the the vast majority of STEMIs, particularly occurring from pregnancy, occur in the postpartum period. And this is why this slide, one more time, talking about a maternal heart team approach is so important and something that we are working on at Dignity Health, particularly where you have a maternal fetal medicine doctor, an obstetrician, a cardiologist, social work, anesthesiologist, nursing, and pharmacy all working together throughout the whole lifespan of the female. So from preconception counseling, then really honing in on multidisciplinary meetings, plans for labor and delivery, follow-up plans after discharge, but more importantly, long-term education and risk reduction, because we want to follow these women way past their pregnancy, particularly if they have any risk factors that we need to make sure that they're aware of, can put them at a higher risk for heart disease, which I'll touch upon a little bit later in our talk. Now, I talked about pregnancy-associated myocardial infarction. Although it's rare and about 6 in 100,000 women experience it, we know that the mortality is very high. So it's extremely important that we identify it. And we know that women that have conventional cardiovascular risk factors tend to be at higher risk for this. So this is where preconception counseling comes into play again, right? Because we want to make sure that their blood pressure is ideal, that they're not smoking, of course, and that their diabetes is under control. That way we can lower their risk of having any complications, such as a pregnancy-associated myocardial infarction. Now, the vast majority of pregnancy-associated myocardial infarctions occur as spontaneous coronary artery dissection, where you have a spontaneous tear in one of the 3 linings of the coronary artery. And what it causes is blood to form, a hematoma to form, and that hematoma closes off the lumen, causing decreased blood flow and, in all intents purposes, leading to a heart attack. SCAD, as we like to call it, or spontaneous coronary artery dissection, is actually, we're noticing, is becoming a lot more common because we're getting better at diagnosing it and screening for it. Other possible causes of pregnancy-associated MI may be atherosclerosis or clot formation. As we know, pregnancy can lead to more of a hypercoagulable state. Now, I brought up SCAD because it's one type of special acute coronary event that disproportionately affects women. And this slide here really talks about the differences that we see in terms of the pathophysiology of acute coronary disease. And I talk about an inconvenient angiographic truth because if we were to look at this slide here, we see that we have a patient with a right coronary artery, and you can clearly see that there is an obstruction or a blockage. And that's something that an interventionalist loves to see, right? Particularly if a patient comes in with symptoms and a heart attack, because that's easy for them to fix. The vast majority, though, of the time, in women in particular, they may not see this where their large epicardial arteries are normal, but it's actually the little tiny microvasculature where we start to see issues. And we know that, again, men are 3 times more likely to have sort of this pattern, which we like to call the male pattern, which is obstructive coronary artery disease, whereas women have 2 to 3 times more likely to have the non-obstructive pattern, despite having angina or despite having evidence that they may have had a myocardial infarction. And this is when we talk about a term called MINOCA or INOCA, INOCA being ischemia with non-obstructive coronary arteries, MINOCA being an MI with non-obstructive coronary arteries. And we know that women with chronic persistent angina who do not have obstructive CAD have a worse prognosis compared to those without angina, with having increased adverse event rates, poor quality of life, repeat hospitalizations and coronary angiography, as well as consumption of healthcare resources. So this is a very important diagnosis to have. And sometimes it could be a little tricky for us as clinicians to figure out if a patient has a normal coronary catheterization, is it because they actually don't have heart disease and their chest pain and events or from something else, or is it because they maybe have microvascular disease or some other type of cause that led to it? And what are the types of MINOCA that we really need to be screening for? So one could be coronary plaque rupture, which again is when you have an actual heart attack where you had a plaque that became unstable and it sort of ruptured. Or as we commonly see in women, you could have coronary plaque erosion, where instead of rupturing, the plaque erodes within itself. I talked about SCAD, or spontaneous coronary artery dissection, and as I said, it disproportionately affects more women than men. But it could also be a Takotsubo, or a stress-induced cardiomyopathy, where we have so much adrenaline running through our body, it can mimic a heart attack because it puts a strain and stress on our heart, and we typically have a low ejection fraction with this. It could also be a type 2 myocardial infarction where you have a supply-demand mismatch, or maybe vasospasm where the artery spasms on itself, which also disproportionately affects women, intracoronary thromboembolism, myocarditis, as well as microvascular disease or endothelial dysfunction. And let's say, particularly for microvascular disease or endothelial dysfunction, we know that when we are dealing with microvascular disease, it's the tiny circulature where we're noticing that we're having inability to allow the artery to relax, or perhaps it's just constricted so much. And we know that what puts women at higher risk for microvascular disease or endothelial dysfunction are not having good control of our traditional risk factors, such as our blood pressure, our cholesterol levels, or our blood sugar. So really, one treatment for microvascular disease and endothelial dysfunction, despite and not only being anti-anginals, is making sure that our traditional risk factors are optimal by making sure that those our blood pressure is under control, our cholesterol is under control, and our blood sugar is under control. Now, this slide, I think, is really profound because it really paints the picture of what I, at least during medical school, learned, is that in order for us to have an abnormal, non-invasive test, you need to have an obstructive lesion. And the fact is, we know that is not true anymore, because we know that you can have a completely normal artery and still be extremely symptomatic. And this is where the microvascular disease comes into play, because again, it's not the epicardial arteries that tend to be affected, but the little tiny arteries that come off of that. And it's so important because now we know that a lot of the non-invasive testing that we were using in the past, perhaps there are better non-invasive testing that we could be utilizing. And this really, I think, paints the picture of the spectrum of different tests that we could use, anywhere from a cardiac MRI, which we do have at Dignity Health, or as well as CT angiography and the importance of that compared to the use of coronary angiography with the catheterization, for example. Or even sometimes the use of PET imaging and using different imaging modalities such as echocardiography with strain imaging, which is more of a computerized system. But really, we know that the working model for ischemic heart disease, particularly in women, is broad. And it's not always just so easy as let's do a coronary catheterization. And if that coronary catheterization is normal, we tell that patient that they don't have heart disease, because the fact is they may, it just may be that they didn't receive the proper screening tool for it. And that's why really utilizing a women's heart health expert may help us to get to the bottom of what's really going on, because we may say, well, perhaps we should use a stress test such as an MRI or a regular stress test, for example, or perhaps we should use CT angiography instead of running straight to the coronary catheterization. Now, another thing that I think is important that this slide shows is that, well, what about our normal artery? How can we ensure that our artery stays normal, I should say? And this is really where now in the cardiovascular world we're focusing more on is prevention. I think in really all specialties in healthcare alike, our focus really should be on prevention. How do we prevent the disease? And as you can see, the only way to do that is to really ensure our risk factors are under control, because it's these risk factors that really attack the normal arteries and leads to an inflammatory response that could really make that artery start to become abnormal, where it could then begin to have microvascular dysfunction or have subclinical disease. So let's talk a little bit about these risk factors. And do cardiovascular risk factors affect women in the same way as men? As you can probably see with the theme, the answer is going to be they do not affect women in the same way as men, because women actually have more risk factors than men, particularly female-specific risk factors. And I want to first talk about the traditional risk factors that we learn always in medical school. So high blood pressure, high cholesterol, and smoking. These are key risk factors for heart disease. And we know about half of Americans have at least one of these three risk factors. Several other risk factors include diabetes, any patient that's overweight or obese, anybody who has a poor diet, physical inactivity, excess alcohol use. Of course, we know family history, particularly first-degree relatives. If you have a male relative less than 55 or a female relative less than 65 is a risk factor. And we know that age is are risk factors as well. The older we are, the more likely is our risk for heart disease, in that any male above the age of 45 and any woman above the age of 55. And it's really these risk factors, the blood pressure, diabetes, the weight, the poor diet, the physical inactivity or excess alcohol, that makes heart disease 80% preventable. Because those are risk factors we have control over. We, of course, don't have control over our family history, and we definitely don't have control over our age. But the fact is that these are the risk factors we like to focus in on, because these are the ones where we can see actual change to ensure that we reduce one's risk of cardiovascular disease at least 80% of the time. Now, what about those traditional risk factors when it comes to sex? Well, the fact is we know that high blood pressure is more common in older women than men, and it's a stronger contributor to cardiovascular disease in women. And despite us knowing this, women are less likely to be treated appropriately for blood pressure compared to their male counterparts. We also know that smoking can increase the risk of heart disease by 25% or more in women compared to men. So if a female smokes for the same amount of time and the same amount of cigarettes as their male counterpart, they're 25% more likely to have a heart attack or some form of cardiovascular disease, including a stroke, compared to their male counterpart. Similarly, diabetes increases the risk of heart disease 3 to 7 folds in women, where it only increases it about 2 to 3 folds in men. We can say the same for obesity. A woman who is obese, which implies a body mass index above 30, is at a 64% greater risk of having a heart attack compared to a male who's at about only 46% risk. We also know that women are more likely to have physical inactivity, for example. So these are risk factors that we really want to educate our female patients about, because even though if their male counterpart has this, we know that they're at a much higher risk of having a heart complication from it. We also know that there are more pregnancy-specific risk factors, and this was brought up with a statement or presidential advisory that was released by the American Heart Association and the American College of Obstetrics and Gynecology, where they wanted to really focus in on the fact that vast majority of young women don't have particularly a general practitioner that they see, because they tend to utilize their obstetrician or their gynecologist as their general practitioner. And this is an opportune time for the OB and the GYN to work conjointly with the primary doctors in the community or even cardiologists to not only screen for traditional risk factors, but also screen for female-specific risk factors that may place one at a higher risk for cardiovascular disease. So what are these risk factors? One of them is polycystic ovarian syndrome. We know that polycystic ovarian syndrome can increase one's risk of cardiovascular disease. So really figuring out if a patient has this is such an important thing. Similarly, menopause. We know that our risk of cardiovascular disease increases markedly after menopause. For any female that has had early menopause, which is defined as before the age of 45, there are some papers that do also define it before the age of 40. We know that they have a 95% higher risk of a future heart attack. Early menses as well, before the age of 12, increases one's risk of cardiovascular disease. And when we talk about hormone replacement therapy, we know that as the patient ages, it can increase their risk of cardiovascular disease. And the way we like to think about hormone replacement therapy is that this was looked at, as we know, in the Women's Health Initiative, where they actually looked to see if hormone replacement therapy can lower one's risk of cardiovascular disease. We know that that is not the case. If anything, some studies have shown it can increase it. The only thing hormone replacement therapy really truly helps with are the psychomotor symptoms of menopause or perimenopause, such as the hot flashes. So if I have a patient who's having extreme distress and they want to think about using hormone replacement therapy, what I tend to do is really see what their overall risk is. If their risk is low, then they can cautiously start it. But if they're in that intermediate or high risk, I may advise that they hold off or think about other measures, because we know that they're at a much greater risk of having cardiovascular disease. We're also now really wanting to ensure that women are weaned off of hormone replacement therapy by the time they're about 55 to 60, because we know that their risk is even further as they age. So this is something that I think is really important for primary doctors to think about outside. And if you have any confusion, sometimes it is important to get advice from a women's cardiovascular expert who may be able to kind of guide you in terms of who hormone replacement therapy may be safe in. Now, what about pregnancy? As I mentioned, we know that pregnancy is the leading cause of maternal mortality, and a lot of things that occur during pregnancy really can place a woman at a higher risk for a cardiovascular event. A lot of this includes our hypertensive disorders of pregnancy, so gestational hypertension or preeclampsia, for example, where we can see a threefold greater risk of cardiovascular disease in women. We also know anybody who's had preterm delivery, less than 37 weeks gestation, that could be an increased risk of cardiovascular disease. We also know that if you had even very preterm delivery, which is before 32 weeks gestation, that puts you at an even greater risk for cardiovascular disease in the future. The same way gestational diabetes does. We have a fourfold higher risk of cardiovascular complications, with a 59% higher risk of myocardial infarctions in women that have gestational diabetes. And having an infant that's defined as small for gestational age can also increase one's risk of cardiovascular disease. Remember, having a child, having infertility treatments, having multiple miscarriages can also increase one's risk of cardiovascular disease as well. So screening these women are so important. And what I'd like to stress again is that any complications during pregnancy, 50%, it puts a 50% increased risk of all-cause death, making cardiovascular disease the leading cause of maternal death in the United States. But these risk factors that I talked about, the hypertensive disorders of pregnancy, the preterm delivery, the infants for small gestational age, or the gestational diabetes, these are risk factors for cardiovascular disease in the future. But it's not the far future, it's really the near future in the next 5 to 10 years. So these are women that at least once a year really should be focusing in and seeing a cardiologist, particularly one that focuses on women's heart health, to ensure that they are optimal when it comes to their traditional risk factors. Now, what other risk factors do we think about when we think about women, particularly those that are more prevalent to women? And these include inflammatory rheumatologic conditions, such as rheumatoid arthritis or lupus, for example, that could increase one's risk by 50% for a cardiac event. We also talk about breast cancer treatment. So we know radiation or chemotherapy can increase the risk of cardiovascular disease, particularly because those are toxic to the heart. And any women with pre-existing cardiac risk factors actually have a greater risk of having a cardiac event if they were to need radiation therapy or chemotherapy. So screening is so important, and working with our oncologists in the community is so key. Just like working with our rheumatologists for the inflammatory rheumatologic conditions is key. Another area where we like to work on is with our social workers or psychologists or psychiatrists in the community, because depression, anxiety, and chronic emotional stress, more prevalent in women, can double their risk of cardiac disease. And this is more so important for women that have been diagnosed with a heart attack or some sort of cardiac condition, because they're at the greatest risk of having depression and anxiety, and it could lead to a recurrent event. So at Dignity Health, we're actually working on ways of how to cope with this, which I'll talk about. Other non-conventional risk factors, which could actually probably more so affect both sexes, include other chronic inflammatory disorders like inflammatory bowel disease, HIV, psoriasis, as well as sleep disorders that put one at a higher risk for cardiac complications. The fact, though, is that there's really good news out there that we as clinicians can educate our patients on these risk factors, but also educate them on steps to improve or lower their risk of having a cardiac event. Because again, heart disease remains preventable 80% of the time. And if we have more optimal risks, then their likelihood of having a cardiac event is much lower than those that have higher risk factors. And what I want to focus in on is really what are the things that we should be educating our patients. And a lot of it has to do with the American Heart Association's Life Simple 7. So making sure that our patients are staying active, they're controlling their cholesterol, they're eating better. And really what they should be eating is a plant-based diet. We know that that has been studied and has lowered one's risk of cardiac disease. Plant-based diets that people really focus in on is the Mediterranean or DASH diet. We also know managing blood pressure is so important, losing weight, reducing blood sugar, and of course, if they're smoking, stopping, including vaping. I also like to include stress management and mental wellness, because this is really the 8th eighth step of Life Simple 7, because that is so important. As I showed you, particularly for our female patients, it could double their risk of cardiovascular disease. So really ensuring we hone in on stress management and mental health is key. So this really asks us the question, what should the approach be? And I like this picture here because it tells us the approach should be following these female patients across their lifespan. Really from even when they're babies, educating them on the fact that their greatest risk is cardiovascular disease and ensuring they're living a healthy lifestyle all the way to their older age. And the approach that I like to do is really, the first thing is assessing their atherosclerotic cardiovascular risk. We can do that with the use of our pooled cohort equation. We want to, of course, include family history to it. But one other thing is that's so important is considering the use of a calcium score. So should we order a calcium score, and who should we order a calcium score on? We know that a calcium score is a test that measures the amount of calcium in the walls of the heart arteries. That calcium is really depositing in the heart, and it's really, for all intents and purposes, the buildup of plaque that can make a heart attack or stroke more likely. We know that the calcium score is one way for us as clinicians to estimate someone's risk of developing heart disease, but it's not necessarily indicated for everyone. And what the guidelines are saying now is really we should be honing in on that intermediate risk group. So anybody that has several risk factors, which usually is 2 or more. But we also need to encourage them to understand that it's also anybody that has female specific risk factors, because those are now by the guidelines called risk enhancers. Family history is very important as well. And I do utilize a calcium score quite often in my clinic, particularly for my female patients, that may have a family history of early heart disease, especially if they have female-specific risk factors that our risk pooled cohort equation doesn't include. So the use of a calcium score may be one area that we should be thinking about. After we assess their risk, we also then want to screen for sex-specific risk factors, many of which I talked about. We then want to also assess for women-predominant conditions like lupus or breast cancer if they were treated with chemo or XRT or anxiety. Or let's say we've diagnosed them with ischemic heart disease. We want to really consider more women-specific conditions like MINOCA or myocardial infarct with non-obstructive coronary arteries, which could be SCAD or multivessel microvascular disease or Takotsubo cardiomyopathy, for example. And then lastly, we want to personalize it for our patients. And how can we personalize it? Well, this was a really nice graph that was looked at in the Circulation Go Red for Women article that was released in February of this year. And ultimately, they talk about different steps. So one, again, is screening for these sex-specific risk factors. But then if they do have sex-specific risk factors, assessing them for the traditional risk factors that we can control. And if we see that their traditional risk factors are not optimal, implementing Life Simple 7, which is what I addressed with you, and ensuring that we treat them early. Because again, if we treat these women early, we can hopefully change the course of them having a cardiac event in the future. And this really leads us to, well, the importance of a women's heart health program. So the Dignity Health Women's Heart Health Program really provides personalized care, the prevention, early detection, and treatment of cardiovascular disease in women. From a clinical perspective, it could be utilizing specialists as a second opinion, for example. But let's say you are one of those female patients that have had someone tell you that you had a heart attack, but your coronary catheterization was normal. Perhaps you need a second opinion for someone to say, well, maybe it wasn't just a false positive. Maybe you actually do have a heart disease because you have SCAD or you have microvascular dysfunction. So really utilizing us as a second opinion. Also utilizing us to have centralized focus point of care to improve any gaps in care that we see. So we talked about a lot of the guideline-directed therapy that's disproportionately not used in women versus men. Ensuring that this program isn't around to really identify that and see as a hospital system how we're doing is really the way to improve quality of care. We also know that collaboration is so important, and the Women's Heart Health Program collaborates with the oncologist, the rheumatologist. They collaborate with cardiac rehab to ensure that women are not only being referred, but also that they're staying in the rehab course. We also, of course, collaborate with our maternal heart team to ensure that our female patients are receiving really adequate and really the best care. Because as I said, cardiovascular disease is the leading cause of maternal mortality in the United States. The program also focuses in on research, any gender-specific research studies in particular, such as our genetics program that's up and running. We also like to increase enrollment of women in research studies. We also have multiple community partnerships, education and health literacy, such as CMEs, like this virtual lunch and learn, or our annual CME, which is the Women's Heart and Vascular Symposium, which will be in November of 2020. We had a successful one last year where I think it really changed practice of many of the providers and clinicians in the community. Now, one thing that I wanted to end with is one thing in terms of community support that we've been working on, and I'm very proud of at Dignity Health, is our support group. This is a group that's led by patients that are females that have had some form of cardiovascular disease, and they lead a monthly support group where they provide education and support to female patients in the community that may have been diagnosed recently with a cardiac condition. They also volunteer by going to the hospitals, and they work closely with our cardiac rehab program as well, really to provide that psychosocial support. As I mentioned, anxiety, depression, and chronic stress are really things that we need to be honing in on, particularly for our female patients. And I think this support group really provides that. It also is important for women that may think they're at risk for cardiovascular disease to be a part of a support group like this as well, because we do invite clinicians in the area for the first 20 minutes or so to provide a didactic session of education. So it's been really helpful and informative. And if you are interested in enrolling your patients, the number is on the screen, 480-728-5414, where you could speak with our coordinator. So with that, I'd like to just take time to ask anyone if they have any questions in particular about the presentation. I think really the take-home points is that having a women's heart health program really allows us to not just ensure that our female patients are getting or receiving really good quality care when they come to the hospital with any acute coronary issues, but also that we're preventing any cardiac care or issues from happening in the future. And that's where we work with the oncologists, the rheumatologists, the maternal fetal medicine physicians, and the obstetricians in the community to really ensure that we engage these women. So with that, if there are not any questions, I'm going to give the microphone over to Susan so she can kind of conclude a few housekeeping steps.
All right, everyone, wraps us up. Let you get back to seeing your patients. We hope you join us for future CME Lunch and Learn programs. Please make sure that if you did send us your email, make sure that you receive the instruction email within the next hour. If not, please get in touch with me at 928-699-4797, or you can email me at susan.bray@dignityhealth.org. I'll keep the WebEx on for a few minutes, so if anyone's having problems with it or if you have any questions. And again, thank you for joining us for this Lunch and Learn series.